We work both internationally and internationally. So now let's go on to our barometer. So 711 doctors who were interviewed by telephone, by post, or through internet answers. And I must say that the company called them up each time there weren't enough answers. This was between September to November 2013. This is the breakup in France. It was fairly homogeneous, lots of Parisians, and that's to have all our provincial doctors blushing. Maybe not so much in the north or the east, but as you can see, it's an interesting breakup here in figures. And if you look at the barometer that was carried out in 2011, we have more than double the answer rate. We have 711 this year, so that's great. We have a lot of doctors who come from teaching hospitals, and there are quite a few of them. There were private clinics, 19% who accepted to answer this question. And now the profile. We spoke to medical oncologists, radiotherapists, gastroenterologists, and dermatologists. Hematologists as well. There were more male doctors, so we didn't respect the gender parity as expected. Now, as far as patients were concerned, we spoke to 1,562 patients. That's really not too bad. So this is an important cohort again, and this was noticed by several newspapers that accompanied us. So it happened again from the end of last year to the beginning of this year. So now the establishments, the hospitals, it was essentially public hospitals rather than private hospitals. But that's because we used interns, and most of our interns are in public hospitals, and there are not many in private centers. So it was very difficult to mobilize teams in private centers to seek out patients, because that used up too much time. And we do hope that in the future we'll be able to work a little more with the private sector. However, having said that, it was a fairly homogeneous distribution. Now, identification of disease, it was essentially breast cancer, and the second one was hematological cancer, digestive cancers. We worked with VCD in 2010. We've done that again this year. And once again, all our thanks to here. So we had a lot of breast patient cancers, and a lot of them at the adjuvant stage. The other half was either in the palliative or the metastatic stage. Most of them had chemotherapy, either as adjuvant or metastatic. Most of them had already been operated, and 1/3 had already undergone radiotherapy or were undergoing radiotherapy. Now, targeted therapy results here are fairly interesting. On the whole, there are just 25% who are getting this targeted therapy. So, two answers that were given was, had they heard about targeted therapy? The figures are not so high, not as high as we thought they would be compared to 2010. Are there support organizations more and more? Yes, indeed there are. So that's brilliant. Hip, hip, hooray. We succeeded. In 2010, we got some information saying that there are 71% hospital organizations that have set up this care system with other newsletters and so on. All that we keep trying to do, all that we do during national and international congresses for this sort of care. So gradually things are gelling. So we have organizations which are now doing this. These are doctors who are giving us answers, so they are aware of what's happening in their own hospitals. This is the distribution. It's essentially in the DISPO, which is the interdisciplinary department for supportive care. Like we have over here at the George Pompidou, we have a department which is just for that. Supportive care, cancer unit, Pompidou. And in the other private or public hospital centers, most of them have to be organized in order to provide this sort of care. Now, the idea of a single window is very rare in 3% of cases. And this is just meant for the cancer centers, cancer fighting centers like we have in America. Plus, what they don't have is the so-called filtering file or filtering sheet so as to direct the patients where they should go. Now, financials. 42% of these hospitals actually apply it, and 10% say that doctors know that it is there, and 48% don't really know about it. So this is important. Very often we say that supportive care costs a lot of money, but it doesn't really cost. It does cost something. It costs society something, but it is quite financially useful for the hospital, much more than some other hospitalized services. So this is financially good for the hospital. It's also very good for the patients, all the organization that a patient requires, and then from an economic and financial point of view, it's important for hospital. So we need to actually make them all aware of this and apply it, that there's some financial aid. Now, there's also multidisciplinary consultation reunion that takes place. Does that exist? Is there any discussion within the main bodies? Now, 40% of the hospital or clinical bodies have actually set up this sort of thing. And for 60%, it just doesn't exist. And in 73% of the cases, we've talked about it. That means that supportive care is now part of discussion within the team. They think about it. Today, practitioners talk about it. So we are moving towards a more universal look at risks and suffering of patients. This is of its inclusion in a real device, a real mechanism for care support and so on. So what is the perception of supportive care by patients? Now, we heard about cancer, prostate cancer, and the difference there was in perception between doctors and patients. So now, what do doctors think about it? Virtually all doctors feel that palliative care and psychological help, it's all this, is social aid, dietitian and consultation when the results are given. And then you see you've got others like nutrition, physiotherapy, real help at home, religion, aesthetic care, etc. Now, 60 or 63% of our patients, however, are suffering. What do patients feel? Patients feel this idea of consultation for psychology, for nutrition, for when the final results are given in 55% cases. So there's a big difference between what exists on the sites and what is actually proposed to the various patients. I'm not criticizing anything, and we are not going to suggest a psycho-oncological supportive care for all patients or even 100% dietitian's care. But is there a screening done for most patients? When you see that when the final results are given, which should be for 100% cancers, you find that it's only in 55% of the cases. Now, patients declare that they have actually had at least 49% when the final declaration is made, 40% for nutritional help, and 31% for psychological help. Now, regarding nutrition in France, virtually 40% of the patients were undernourished. So this fits well when it comes to nutritional management. But once again, consultation when the final results are given. I think it's about time that we reacted to the role of this ability to have some help. And think about how it's done. Is it included? Is it really part of the coordination that we have for looking after the patients? This rule was developed in a particular role that nurses can play. So we call them clinician nurses, to answer questions to which people have no answers today. So that's a possibility to think about it. Social help, 22%, doctors, 20%. But when you look at what's happening in the mouth, with Mr. Bensoudoun, we realized that perhaps we need to improve in this field? So who are the health professionals around patients, and who's your main doctor? And who's going to talk about it to patients? And normally it is your entitled oncologist for the doctors. This is the doctor's answer. 78% of them say that I'm the one who answers and I'm the one who talks about supportive care. This is less than in 2010. In 2010, it was 88%. On the other hand, if you look at results for the announcement, it was 57 in 2010 and 41% over here. So we need to take a second look at all this. Then we have dedicated teams also, and which are gradually increasing with perhaps outside consultants too who come in. So who makes the proposal of this sort of guiding or consultation? This is patients who answer. In 63% of the cases, they say it's the doctor who refers us. So you can see it isn't too far from the reality. Now, this is again interesting data. If you look at what Gisèle Schwesthoff did in Lyon, this was in 2010 or 11, it was her thesis. She showed that time spent with the doctor oncologist, even if it's only 10 minutes, it is the moment that the patient really talks about right through the entire care period. You talk about the outcome, you talk about the treatment, but this is exactly what the patient remembers. So when you see the results, so if your main oncologist really dedicates himself to suffering and also supportive care, and if he can actually identify 2 or 3 items which he then hands over to the relay, then it would be as what the patient said. Now, the care providing team is also very important when it comes to making the supportive care proposal, 42%, as opposed to just nurses were there. Now, without casting stones at our nurse friends, I think it's about time that we discuss all this with them again. How do you actually talk about this supportive care for the first time, and how you actually discuss the people who would be providing this care. Now, to talk about the contact with the medical corps, because it's all very well to say that your reference oncologist or your main oncologist, is he being seen often enough? Now, as opposed to the private sector, 23% of the time he meets them on demand, once a month or more, 38%, so this is regular. So they are well dedicated to their patients, so otherwise it's once every 2 months, once every 3 months, and that must be for your tumor assessment. So there is a contact with the main doctor which is fairly frequent. Now, what's happening in the private sector? Now, what is the reference doctor doing? Because we keep talking about the first, second, and third cancer plan. The GP must work with the GP, but the hospital doesn't work with the GP. You have to work with those who are in the hospital. What do patients feel? They feel that the main contact in the private sector is the GP. And that's 84% of them who say that. And they are going to be the first ones to talk about supportive care. Does he know what supportive care is? Does he know what it refers to? All the organizations and all? Perhaps no. So this is what we need to do with our GPs, because they are our relays out of hospital, so we need to work with them. Now, self-employed nurses, 58% of the answers, pharmacists, 52%. So 1 in 2 patient feels that his or her pharmacist has a very important contact in out of hospital. So, yeah. So as you see, we have a role to play when they leave a hospital. Now, quite obviously, most programs which are developed to make this link between what's happening in a hospital and in the private sector should be through these 3 points of contact. How often do they meet the GP or the family doctor? On demand, it's 60%. On demand is, I call my doctor when I'm not feeling well. Doctor, I'm not well. Oh, you haven't seen me for 3 months. Why didn't you call me earlier? Because I was with the hospital and now I want you to come and see me at home. What happens with the GP? When the patient was in hospital, the doctor wasn't aware of what was happening, what sort of therapy was provided, and so on. And he's now being called to help or support the patient. So here again, I'm sure we've got something to do. We must strengthen this link more systematically, more regularly with the general practitioner, so that he isn't just dependent on a patient demand, but that he's really involved in the entire care program of the patient. So see the patient more frequently and have a better idea of his follow-up. So are there coordination organizations for a follow-up out of hospital? 57%. That's better than in 2010, where it was only 40%. So now there are links established, contacts established with the private sector, but it's still on non-hospital background. Now, in terms of the kind of support that's provided, the treatments, we talked a lot about guidelines, and we'll be doing it again tomorrow. We talk of all this treatment for patients, but are they well informed? Now, of course, there's an ethical reason for all this. This data is, however, all said and done, very important. So now, patients treated for ASE, are you aware of these erythropoietic stimulating agents, are you aware of what it does? Thrombosis, say 77%. Yes, I'm aware. And it has an potential impact on survival. In 2010, it was just 19% who said yes. No side effects, 13%. No effect, 21%. Do you talk about it to your patients? Do you talk to all your patients about this risk? And the answer is yes, in 49% cases. That means in 51% cases, you're aware of these side effects, but you don't inform the patient. So this is the doctor's point of view. This is a verbatim. Either I make this declaration or I don't. I share this information with my patient or not. So how often do you ask your patients for their feedback? Now, those treated with morphines or morphine-based medicines, do you talk about side effects of the treatment? So it's 74% patients that you inform them about the use of morphine-based medicines, the morphinics, because you know more about them. And they inform them just because they know them better, but do they know about the guidelines? Now, we talked about guidelines, and the answer there is not necessarily well known. Do we apply them? Even less. Now, for those receiving morphinics, do you always prescribe a laxative treatment? And the answer is yes, in 48% cases. What is the main risk of these? It's constipation. Normally, you're supposed to prescribe a laxative systematically at the same time, but it's not done. Do you prescribe antibiotics? And there the answer is even more hazardous. Now, let's look at the patient side. When you get supportive treatments prescribed, yes, we do. And who makes the proposal? So it's my oncologist 74% of the time. So once again, it's this oncologist who is behind prescription and so on, be it antiemetic, antalgic, and so on. Whereas the GP is only there for 15% of the supportive care therapy. So is he aware? Does he know about it? Does he know the guidelines? Probably not, because he doesn't prescribe them very much. So how do I work on a treatment that I don't know about and which I rarely apply? It's difficult. Did you hear about the positive effects of this supportive care? 70% said yes, great. Who told you about it? My oncologist. And now the last line, my pharmacist, yes. Yes, I heard about the positive effects in 6% of the cases. Now, he is a professional also in drugs, so Jean-Baptiste would perhaps mention this at the next Congress. We feel that the pharmacists should know more about the drug, and we should work in greater cooperation with them, because if you remember, he is one of the main pivots for patient management at home. Now, have you heard about the negative effects? That's a little more difficult. 74% yes. Who spoke to you about it? Oh, my doctor, my oncologist. So now that's a good thing. So the next line, and that's the pharmacy. 7%. So talking about positive effects would perhaps be the role of the prescriptor, but negative effects is the fundamental role of the pharmacist when he's actually delivering this medicine. So we have to now work with pharmacists who've been absolutely out of cancer plans 1, 2, and 3, slightly in 3. So really, it's a must that we enhance their role, and we in cancerology, we must promote this link or contact with pharmacists and chemists, and perhaps via our hospital chemists. So now, finally, different stages of the disease and the medical supportive treatment. Is it always suggested? Yes, between 36 and 45% at the adjuvant stage, and that is for breast cancer. So it's the normal treatments, so you have grade 5 for vomiting, for LAFSOS, and for MAS it's 4, high level for Americans at ASCO. So normally there should be a prescription for all patients, an anti-emetic one. It's only 40% of practitioners who prescribe a support treatment as adjuvant. But when you get to palliative phase, most of the patients go back and get a supportive treatment. So it's exactly the same for the non-drug treatment. So be it the organization or the drugs and so on. For a patient, we talk a lot more, as you say, at the palliative stage rather than at the diagnostic stage or of the adjuvant stage. Do they know what an adjuvant stage is? So 1/3 of them say yes. 66% of them don't know what supportive care is. They just don't know what it is. We talked a lot about it to doctors, though we still need to make progress because we feel that support and so on is only at the terminal stage. Sorry, I shouldn't be saying terminal, I should be saying palliative care. So we should work more with the general public, and that's why we had press conferences, not to say that we've done some wonderful work, but to inform the general public about supportive care, the definition, and so on, how this management comes in, and what to do with cancer. So there's improvement in quality of life and also a better, improved tolerance to the treatment. Finally, how do you define supportive care? Patients say they have all sorts of definitions. It's additional treatment. It is medicines to improve the efficacy of the existing treatments. It's a melting pot of all sorts of things. We don't really know what it is. On the other hand, palliative care, this is widely known for most of them. Have you heard of palliative care? Yes, 80% said yes. And what is really interesting over here is the definition given by most patients. 60% of the patients say that this is a sort of supportive care to improve quality of life. So, but this is what it is. It's supportive care. Now, what happened in Boston a month ago? A month ago, we had MASC, supportive car. David is present over here, and LASCO, with the development of supportive care and palliative care coming together. And then the Association of Palliative Care and Hospitals. So these three entities met together, and this has created a new perception, perhaps to develop a message for the general public, not necessarily with professionals, but with the general public. So this is patient-centered care. The patient is really at the very heart of this management. And we need to do the same thing. We need to talk about it to the general public without dropping out anybody. So there's absolutely no question of doing away with palliative care or with supportive care. The idea is that we work together and we promote a proper patient management from diagnosis right up to, if necessary, the terminal stage or the post-cancer stage, which is what we call survivor care in the States. And in conclusion, there's a lot of progress being made, and they will keep increasing in all the areas and establishments in France. Special effort has to be made on information on what supportive care is and the therapy that involved is, the beneficial effects, and the downside of all these treatments. Now, between hospitals and outside hospitals, there's a lot to be done. It's very difficult for a hospital person to say it's difficult to get in touch with a GP, and the GP says, I can never get in touch with the hospital. I myself, several times at meetings with GPs, when we tried to talk to them and we tried to organize something, the only answer I'd get was, so what's your phone number? Give us a phone number. Give us a number. It's part of the Cancer Plan 3, but we have to go beyond it. We must include them right from the beginning in the care treatment. So it's a must. When patients see different practitioners, surgeons, etc., and they say, I'm tired, I've got pain, help me, then certainly professionals will be listening differently, and therefore there'll be greater care taken of patients suffering from cancer in France.